Assalamu alaikum. In this recording, we will talk about safe blood handling as a guide from start to finish. During this lecture, we will go through the complete blood handling workflow from sample collection to transfusion. We will highlight critical points for error prevention and clarify labeling, transportation, and storage protocols for blood products. Let's start by talking about the importance of safe blood handling. Safe blood handling is very important because no matter what we do in the blood bank, despite knowing all of the knowledge that we have, despite going to school and studying for endless hours, despite knowing all of those antigens and antibodies, and despite performing all of the tests that we do, essentially the process of transfusion is never going to be 100% safe. It is a fairly safe procedure, but at the end of the day, we are transfusing biological materials. We are introducing foreign biological materials into a patient. And so it will never be 100% safe. Following this workflow prevents the transfusion errors, reactions, and patient harm. It ensures compliance with hospital and international safety standards, and because nurses play a central role in error prevention. The process is simple, really. Starts with a request, continues on to sample collection, which is then sent to the lab for processing and to perform tests. Once the tests are finalized and the component is chosen, the blood bank issues the blood component. From the minute the component is issued, the blood bank then is not very involved in the process of patient safety. From this point onwards, patient safety will largely fall on the nurses, and the nurses become our first line of defense and the most important part of the safety of our patients. What happens after this? The component goes through transportation, the transfusion at the bedside, and the documentation, all of which are very important despite some sounding simple at the start towards the safety of our patients. In a typical day, and this will include a lot of detail that can differ from one hospital to another, so I strongly suggest that every nurse asks to see the policy that's attached to daycare protocols. But usually, when we have a planned transfusion, the nurse calls the patient 1 to 3 days before the transfusion. If this is a new patient, we always suggest that you call in the patient at least 3 days ahead. This way, if the patient turns out to be antibody positive, it would allow the blood bank more time to perform tests properly and to prepare the safest and most compatible unit possible. So you call 1 to 3 days before the transfusion for pre-sampling. The doctor has the job and the responsibility of entering the CBC and transfusion request in the hospital system and fill out the immunohematology form. We collect and send the required samples to the lab, and then you would be required to follow up with the blood bank until the units are ready. Before you start the process on the day, you will be required to verify the patient identity with 2 identifiers. We ask you not to say things like, "Are you Ahmed?" For example, it's best for you to ask the person, "What is your full name?" You should confirm the order in the hospital system and the signed consent. Secure the IV line with an 18 to 22 gauge. Keep the saline ready and do not use that line for any concurrent meds. A lot of the times when we are experiencing transfusion reactions, it is because something as simple as the nurse using the same line for a medication and then following that with the transfusion. We position the patient appropriately in most hospitals at about 45 degrees. If you know that your patient have had difficulties in the past, it might be easier for the patient if they are positioned slightly higher than that. And then we document the baseline information in the daycare records. Once all of that is done, you already know who your patient is, you have confirmed that this is the right patient, you have secured the IV line, you've done all of these pre-steps, then you request the components from the blood bank. Okay, request one component at a time, don't request multiple components, and ensure that the unit is transported appropriately. Send a container with ice if needed and a cardboard or divider. It must be a dedicated transportation container. It shouldn't be the samples box. It should be temperature controlled container, and it cannot be a sample box. Now, if you are requesting red blood cells have to be transported with ice. They need ice, they need the cold to be happier and to keep the validity and viability of the cells better. Now, they need the cold, but they hate being in direct contact with the ice. That's why we ask you to include a divider or at least a piece of cardboard or a towel, whatever you have available at your local hospital, because we will need to put something that separates the ice from the red blood cell components so they don't come in direct contact with each other. Platelets, plasma, and cryo are transported without ice. The platelets are transported without ice because platelets are actually stored at room temperature. Plasma and cryo are transported without ice because those are frozen components that will have to be defrosted prior to the transfusion. Checking the blood. Now, the best and the most effective way of us ensuring the safety of our patient is for all of us to work as a team, but not to trust each other blindly. There are 3 different people that are involved in the process of a transfusion. You have the nurses, you have the doctor, and then you have the lab staff. Sometimes the nurse trusts that the lab staff did everything 100% correctly. The lab staff trusts the nurses trust the doctors trust the nurses, and at the end of the day, when a mistake is being made, the patient has to suffer. If each one of those 3 different people, the nurse, the doctor, and the lab person, if each one of them does the work without blindly trusting the others, then one of us will catch the other's mistake before it reaches the patient. We are human at the end of the day, so making mistakes is inevitable. The problem isn't making the mistake. The problem in not having enough steps that prevents that mistake from reaching our patient. So when we receive the bag, the first thing you have to do as a nurse is visually inspect the bag. What are you looking for? Number 1, does the bag have any leakage? Is it leaking from anywhere? Number 2, does it have a weird color than usual? Number 3, does it have a weird turbidity about it? Any of these signs would indicate that the blood bag is not safe. If you notice any of these, then you should call up the blood bank and describe what you are seeing in the bag to make sure that it is safe to transfuse. Number 2, we need to double check the information. This is done by 2 different individuals, the nurse and the doctor. You're checking for the name, you're checking for the hospital number, you're checking for the civil ID, the ABO, the RH, that they are compatible, and the expiry of the component. When you check for the name or the hospital number or the civil ID, you do not check any of these partially. I don't only check the first name. I will not only check the last 3 numbers of the hospital number or the civil ID. We check the entire information. For frozen plasma, if the lab takes care of the thawing process, that's fine. If the lab expects you to take care of the thawing process, then the thawing of the component has to be done through a dedicated machine under a controlled temperature for a specific amount of time following your local policy. So what exactly are we checking for? There's going to be, in some cases, a paper that's attached to the component that signifies what this component, who this component was reserved to, and then there will also be all of the information corresponding to your original request form. Number 1, you need to make sure that the paper that was attached to the component is attached to the correct component. So I'm looking at the unit number and I am making sure that it matches the unit number that has been written on the paper. Number 2, I need to make sure that this matches my patient. So I'm looking at the unit number here, which matches the number on the actual unit, and I'm making sure that it matches the number on the unit on the request form as well. Number 3, we need to make sure that this is actually our patient. So we take this, we take the form, and we go at the bedside to our patient. We say to the patient, state your full name, and we double check. We make sure that this is the same patient, and then we ask for a second identifying feature. So for example, we tell the patient, give me your full date of birth. So it will give you the full date of birth, and you can check that this is your correct patient again. We look that the blood group is the actual blood group and it matches exactly the blood group of our patient. If, for example, my patient blood group is O positive and this unit is O negative, technically that is a compatible blood group for my patient. But if it's not indicated here that I have given the patient O negative, then something is wrong and you need to follow up with the lab before you start the transfusion. In the world of compatibility, you will always have what's known as a first choice and then a second choice. In some cases, you might have a third or a fourth choice as well. Blood group O, for example, will have O as a first choice and will not be able to receive blood from other blood groups. Group A will receive blood from A donors as a first choice, O for a second choice. Groups B will receive blood from B donors as a first choice, O as a second choice. Blood AB will receive blood from an AB, second choice will be A, third choice will be B, and fourth choice will be O. When it comes to the RHD compatibility, RHD negative patients, so everyone that's negative, only receives blood from negative. RHD positive can receive blood from either positive or negative patients. Immediately pre-transfusion, we have to record the time that we received the component in the patient record. We assess the baseline vital signs, record them. We review the past transfusion reactions, if any, to be able to watch out for any possible reactions. And we use the blood tubing with a filter. We prime the set with the component. And we start the transfusion promptly after the issue. We start within 30 minutes of the issue, and we try to return the component if that is not possible for any reason. This is mainly why we ask that the nurse only requests one component at a time for the transfusion. Because once you ask for the component, you have to start the transfusion as soon as possible. In Kuwait, hospitals expect the transfusion to start within 30 minutes of picking up the component from the blood bank. In other countries, this number may vary slightly, but I believe that most countries are the same. The transfusion has to be completed within 4 hours. So the 4 hours start from the minute that your transfusion starts. If you start your transfusion at 12 and then you notice something that the doctor subsequently asks you to pause the transfusion from 12:20, for example, until 1:30, and then at 1:30 the doctor says you can resume the transfusion. The transfusion has to be completed by 4 p.m. anyway. So the 4 hours do not pause when you pause the transfusion. The time that you pause the transfusion still counts. We have to begin the transfusion at a slow rate for 15 minutes. And then we can increase the rate of the infusion. This is because with the possibility of a major incompatibility, signs of severe transfusion reactions will appear probably within the first 15 minutes of the transfusion. So it is very important that during the first 15 minutes, the infusion rate is slow and we are right there by the bedside watching our patient closely for any signs of a transfusion reaction, to be able to stop and pause the transfusion if any signs of transfusion reaction appear, and therefore protect our patient and ensure their safety. This is an example of the transfusion, the optimal transfusion time and the rate for adults depending on the different components. Monitoring during the transfusion. After the first 15 minutes, where you're just right there looking at the patient constantly, the patient has to be observed at minimum hourly for adverse reactions. I believe that the policies for nurses in Kuwait says every half an hour, but in general, mostly the patient has to be observed at least at a minimum hourly. We need to change the transfusion set every 4 hours and between components. We also need a new set for each platelet transfusions. When you observe any possible transfusion reaction signs, we have to stop the transfusion immediately and document what happened. When I say you have to stop the transfusion immediately, I don't mean that you disconnect the component and remove the IV line. You only have to stop the infusion rate, but keep everything as is until you assess carefully and until you inform the doctor and learn back how to proceed. Post-transfusion. We flush the tubing with saline and then we discontinue. We document the completion time, the volume, any reaction status, and you sign to verify the document. We assess the vitals 15 minutes after the transfusion has been completed, and we instruct the patient to report any delayed symptoms. Usually in face-to-face lectures at this point, I ask the nurses, how long do you think a transfusion reaction can occur after the completion of a transfusion? What do you think is the maximum amount of time that can show signs of transfusion reactions? And up until now, I haven't had a single nurse that answered the question correctly. And it's because a lot of people are not aware that transfusion reactions can occur not only days after the transfusion, but decades. In severe situations with some infections like prion infections or HIV infections, the virus or prion can have an incubation period of up to a decade or 2 decades, after which the patient would exhibit some symptoms. So transfusion reactions can happen minutes, days, weeks, months, or years after the completion of a transfusion. And you have to dispose of the component bags according to the policy of your local hospital. Compatibility quick guide. In general, red blood cells have to be ABO and Rh compatible. Plasma has to be group specific. For platelets and cryo, in most hospitals, or groups are going to be acceptable. Usually the blood bank will try to match the blood group of your patient to the best of their abilities, depending on their available stock. If you are the kind of nurse that doesn't have to be responsible for transfusions very often, and so this information is harder to retain, I do suggest that you find a version of this diagram or graph. It shows compatibility for red cells, for plasma, for platelets. There are several examples of this that are available online. You should probably also have something like this in the policy in your local hospital. Documentation. The request form is very important for requesting tests, component preparation, and for collection. And then you'll have the transfusion record form, which is used pre, during, and post transfusion to record all the required information. It is very important to maintain documentation for several reasons. Number one, the hospital will be able to perform audits periodically to identify any gaps. It helps us identify if the staff are not aware of certain policies. This way we can teach the staff those policies. It can help us identify any trends in transfusion reactions, which can then show us any gaps in the knowledge or the practices that are done in the hospital, and it helps us identify them. So documentation is never going to be about punishing people and finding out who's doing something wrong. It's mainly going to be to ensure the safety of our patients to the best of our ability. In summary, let's follow the workflow strictly. Let's double check at every step, because you are the most important part in ensuring the safety of our patients. Correct documentation is very important, and nurses are the key to transfusion safety. Thank you.